Hi there, this is Ben with HCO Thrive. Welcome to another healthcare provider news roundup. This one is for March. Per usual, we'll start with news regarding hospitals and or systems and overall healthcare news, followed by skilled nursing facilities and then home health agencies. In terms of themes, it includes some financial updates, a bunch of research studies, and then a few interesting opinion pieces. The first article is from Becker's Hospital Review. It's more of a note, and it's about the March 6th Bureau of Labor Statistics results. As you can see, healthcare actually lost jobs, whereas it had been growing previously. So healthcare employment decreased by 28,000 jobs. This is a decline following the fairly large gain in January that we talked about last time. Within healthcare, physician offices lost 37,400 jobs in February. So they posit that this reflects strike activity. Meanwhile, hospitals added 11,600 jobs, while employment in nursing and residential care facilities jobs declined by 5,600. And then overall, healthcare had added an average of 36,000 jobs per month over the previous 12 months. So we see a bit of a reversal of previous trends, but we'll have to wait and see what happens when the data comes out for this current month of March. This next article is also from Becker's Hospital Review, and it's titled Payer-Provider Transparency Campaigns Could Signal Deeper Tensions. So as you know, the government in particular has been very big on transparent pricing, and this article talks a bit about that and sort of the inherent tension between hospitals and then payers. It says payers and providers have been engaging in a slew of transparency campaigns, with some aiming to expose pricing and denial concerns. One of these that's come to the forefront is called Hospital Watch. And again, the article posits that they're shifting blame to hospitals. A group called Better Solutions for Healthcare oversees the project. Why is that important? Because it includes Blue Cross Blue Shield Association and AHIP as members. So as you can imagine, many hospitals feel there is a bit of a conflict of interest. Although Hospital Watch's main purpose is to focus on price gouging by corporate hospitals, they also include data for payment incidents that include nonprofits and academic medical centers. As you can imagine, and as I just mentioned, providers aren't exactly thrilled with this. Here's a good quote. "This isn't a watchdog effort. This is insurers deflecting from the fact that they have continuously increased out-of-pocket costs for patients, making access to healthcare unaffordable for hardworking Americans," a spokesperson for the Federation of American Hospitals said about the campaign. But it's also important to note that insurers are not the only ones launching such campaigns. In Indiana specifically, Indiana Hospital Association's Access Denied initiative focuses on care denials and intends to expose abusive insurer practices. So you can see on one hand, we have hospitals, and on the other, insurance companies. Both are watching each other. And there's questions about how honest or forthright these initiatives really are. This is a good topic for discussion, though, so let me know down below what you think and who you think shoulders more blame, hospitals or insurance companies denying claims. We continue with another Becker's article. This one is Think of Your Hospital as a Startup, What Mark Cuban Would Do If He Bought a Hospital. So Mark Cuban, former owner of the Dallas Mavericks, founder of Cost Plus Drugs, has been making the rounds on podcasts talking about healthcare issues. This article specifically covers what he said on the Healthcare Bridge podcast. And he says he would try and run a hospital like a startup if he owned one. Specifically, he would eliminate unnecessary overhead, prioritize radical transparency, pay physicians well, and then use AI to root out inefficiencies. Getting into a little bit more detail about his suggested approach, foundation of his approach would focus on simplifying operations, eliminating ancillary services, and building trust. And here's a quote. It is the same with cost plus drugs. Our margins are only 15%, but I know the key element for me is how I build trust. And the way to build trust is by having a set margin. So that's certainly an interesting idea. I will say, though, that insurance companies also have set margins, either 15 or 20% max. So I don't know how much that leads to trust in that segment of the industry. Another aspect that he discussed is transparency. Transparency would also be critical to the model. I would put out there and market, look, here's what we pay our doctors, here's our overhead, down to the penny so that you can see what it costs. And here's what we get reimbursed by Medicare, and we'll charge you the same and we'll grow. I know that practice would grow because even though basic Medicare doesn't make you much money, the people who have real issues you can make money from. And this is somewhat interesting given that we just talked about transparency. So his idea is basically lean into being as transparent as possible, providing everything up into including physician salaries. And to be honest, though, I think you can get most of this information. The question is just, how prominently a hospital is going to advertise that to customers. And final issue he touched on is negotiating power, specifically hospitals and systems negotiating with insurers. Negotiating power often determines financial success, arguing hospitals typically fall into one of two categories. One, I have market dominance and I get to say F you to everybody in the insurance companies, right? I don't need you because I'm going to get my own patients too. Or two, I don't have enough patient flow, so I need you insurance companies to send me patients, and so I'll do the deal you want me to do because otherwise I don't have a patient funnel. So obviously this is a bit simplistic, but I get the point he's trying to make. Unfortunately, there's really not a good way for many hospitals to move from 2 to 1. So I'm not sure how much this really applies. So I guess if one was interested in purchasing a hospital, it'd be quite important to take a look at the geographic region and market share and other stats like that. Our final Becker's article we're going to cover for hospitals and systems is a summary of a JAMA Network Open study that asked the question, among resident physicians, do more work hours worsen burnout? And the answer is no. JAMA Network study found no significant association between burnout and weekly average hours in a clinical trial among residents. Researchers tested how an increase in work hours was associated with stress, burnout, and self-perceived competency for residents in high burnout specialties. These include emergency, family, internal medicine, as well as 10 surgical specialties. And the sample was of 540 residents who responded to the survey, and the average hours per week was 65. They found that each 10-hour increase in the average work hours was not associated with more burnout. However, it was associated with higher stress levels and increased self-assessed competency milestones. And to quote, resident burnout is influenced by more than just the number of hours worked. The last part of that is it also depends on what happens at work, which is pretty well established in the burnout literature, which I know a fair amount about. It's really a product of energetic resources, job demands, and other factors like that. So I did think it was kind of interesting that work hours were associated with increased self-assessed competency milestones. I wonder if that's a product of just working more, you get more opportunities, and so therefore you grow more and feel like you're progressing further in your education and your career, or something else. And then more hours did lead to higher stress, but that isn't necessarily a negative if it doesn't lead to burnout. And really the takeaway of it all is that, work designers, supervisors, managers need to pay special attention to the work environment, not just the total number of hours worked. Moving now to skilled nursing facility news, we have a article published in Health Affairs, The Forefront, which is a less technical than a full-on journal article. It's titled, When Falls Are Regulated but Function is Not, How Measurement Incentives Undermine Post-Acute Care. It iterates that skilled nursing facilities collect standardized functional data on every Medicare beneficiary they admit. That would be the MDS assessments for the minimum data set. Clinicians assess mobility and self-care at admission and discharge. Sustained functional decline, such as failure to improve or unexpected worsening in mobility scores, rarely trigger investigation, corrective action, or enforcement. This is unlike falls, pressure, injuries, or infections. So falls are events that demand an immediate organizational response, usually an investigation. Functional deterioration, however, is treated just as expected aging. And this functional decline rarely crosses the threshold from clinical documentation to quality signal. The author argues that the path forward would be to treat functional decline as a trigger for quality review, much like falls are. And the goal is to ensure that unexpected deterioration prompts review, not to penalize facilities that care for more complex populations. The author stresses that this would not require collecting any new data, as the data is already collected in terms of the MDS. The real difference would be just that CMS needs to prioritize functional deterioration the same way they do falls. So not spend all their time focused on falls, injuries like that, and take a more broad approach to overall post-acute care health. The next topic is actually a full-on journal article in Health Affairs. I was alerted to it through McKnight's Long-Term Care, same as the previous article. And it is a study on the effect of unions on nursing home staffing patterns and quality. So registered nurse staffing fell in nursing homes that added unions over a 9-year period, but that did not equate to declines in quality. Healthcare worker unions operated at about 16% of nursing homes between 2013 and 2021, which of course is a study time period. 321 nursing homes were newly unionized in that time. And while RN ratios declined, LPN hours increased, and the researchers reported no evidence that unionization had a causal effect on nursing home quality. A quote from the article, unions do not appear to decrease quality despite unionization leading to cost-cutting responses that reduce nursing skill mix, wrote lead researcher Adam Dean. And the authors also suggest that these results may be consistent with labor unions compensating for RN staffing reductions by increasing worker productivity via lower turnover, better training, and more effective labor management coordination. Our next study from JAMA Network Open took a look at how employing social workers in nursing homes helped reduce the use of restraints. So according to a February study published in JAMA Network Open, staffing of qualified social workers, QSW, was associated with reduction in the use of restraints. This is particularly true in facilities serving residents with cognitive impairment. So the study looked at about 2,500 skilled nursing facilities in the long-term care focused database, as well as payroll-based journal non-nursing staff files from the 1st of January 2017 to December 31st, 2021, so 4-year period. Primary outcome tracked was restraint use, defined as the proportion of residents restrained at the annual certification survey. And a quote, in this cohort study of U.S. nursing homes, QSW staffing was associated with reduced restraint use, particularly in facilities with a higher prevalence of ADRD, said the authors. And ADRD stands for Alzheimer's disease, and related dementia. Our last SNF study also looks at staffing, this time with respect to CNA staffing, and they found that higher levels of CNA staffing lead to fewer fall injuries. Increased CNA staffing is linked to a reduction in injurious falls, while low staff facilities are associated with an increase in fall injury rates. Most nursing homes do not have adequate staffing, however. Nearly 70.3% did not meet the recommended CNA coverage. The study was published in the March edition of the Journal of the Post-Acute and Long-Term Care Medical Association. Looked at 1,100 nursing homes with 1.1 million long-stay residents enrolled in Medicare fee-for-service between July 1st, 2019 and December 31st, 2019. Nursing homes were categorized as having recommended coverage if CNAs provided 2.45 hours or more per resident day coverage. They were categorized as low coverage if CNAs provided less than that amount. And a quote, greater staffing, especially meeting recommended CNA and RN hours, can protect residents from injurious falls, but our findings show that simply increasing hours in under-resourced homes without addressing overall staffing shortages may not be enough. And finally, it's also important to note that these low-staffed nursing homes were likely to have for-profit ownership, close to 80%. These low-staffed nursing homes also had to care for a higher percentage of residents with Medicaid, 63.6 versus 52% for higher staffed. A similar pattern was also observed for RN staffing hours. We move now to home health, and first up is an article from McKnight's Home Care titled Home Care Costs Rise 3% in 2025, Vary by State. A Place for Mom reports that the national median cost of home care for families in 2025 was $34 an hour. That's an increase of 3% from $33 in 2024. The 2026 Costs of Long-Term Care and Senior Living report said. So this data was released from early January 2026 and is based on hourly rates shared by 3,200 home care agencies in a Place for Moms network. Meanwhile, median assisted living costs topped $5,500 a month in 2025, a 4.4% increase from 2024. Memory care costs increased 3.7% year over year to $6,700 per month, and independent living costs increased by 1.75% to $3,200 per month, the report found. One thing I should note, though, is that the 3% or so increase in home health costs is actually less than it has been in previous years, which is a good sign. Our next home health agency article is also from McKnight's Home Health, and this one is about the total number of home health agencies. And recently, in 2025, this number increased, which bucks a decade-long trend of decreases in home health agencies. So according to the 2025 Home Health Chartbook, the number of home health agencies treating traditional Medicare beneficiaries saw an increase. This halts a slide in providers that dates back to 2015. The sector experienced a 1.9% increase in agencies, growing to 9,961 in 2024 from 9,775 the previous year. And this study was originally published by the National Alliance for Care at Home and the Research Institute for Home Care. The Chartbook found a 13.4% drop in home health agencies serving traditional Medicare beneficiaries between 2015 and 2024. But this trend has been reversing. There was also growth in the number of agencies between 2020 and 2021 and between 2022 and 2023. Overall, just 6.2% of total Medicare beneficiaries utilize home health services. Employment at home health agencies continues to climb, with 1.75 million people working in the industry, which is an 18.2% increase from 2020, when home health employed 1.487 million people. And you can expect that number to continue to increase, particularly the employment going forward in the future years. Our final home health agency article and our final article of the day is a study from the American Journal of Geriatric Society. Long and short of it is patients with dementia are less likely to receive high quality home health care. And there are significant variations in the quality of care depending on where one lives. Researchers found that dementia patients were less likely to receive care from high quality home health agencies based on satisfaction of care. And that is the patient survey star ratings, so HHCAHPS, but did not find significant variations in the quality of care based on clinical status measures, the quality of patient care star ratings, which comes from the provider data set for home health agencies. And finally, with respect to geographic variation, there was greater use of high quality home health agencies among people living with dementia in counties in the southeast United States, in states like Mississippi and Alabama, which is a little surprising, but I'll have to take a deeper look at the article and see if they posit any reasons why that might be, aside from the fact there are a lot of home health agencies in the region. And that's it for this roundup. I hope to do another one at the end of the month. If you're still here, thank you for watching. Let us know if you have any questions in the comments below. I'll post a link to a PDF that has all the article links. And again, thank you for watching.